so welcome. After some minor technical difficulties, we're only 5 minutes late. So I'm Lonnie Berger. I am the director of the Institute for Research on Poverty. On behalf of IRP and the Department of Economics and the Lampman family, we'd like to welcome you to the 17th Lampman Memorial Lecture. This has been a really phenomenal series of speakers, and today is continuing that tradition. We're thrilled that we can have Bob Lampman's son, John, here today to join us. And before I introduce Janet Currie, our speaker for tonight, I want to say a few things about Bob Lampman. So Bob Lampman was a professor of economics here for over 30 years. He was the founder and the guiding spirit of IRP. And by all accounts, he was an exceptional and unique scholar, teacher, and mentor, whose legacy looms large over the social sciences building, the entire campus, and throughout policy in the US and beyond. So he was well known as the intellectual architect of the US War on Poverty. He served on the Council of Economic Advisors in the 60s and really led its efforts to design poverty policy and anti-poverty programs. So he actually wrote the chapter on poverty in the 1964 Economic Report of the President, which was really the blueprint for the Johnson administration's anti-poverty efforts. His academic work spanned the gamut of social welfare programs, so it included health, education, means-tested transfers, and Social Security's program. And he was really known for, when he thought about policies, when he considered policies, the very simple question, what does it do for the poor? So more personal to IRP. So in the early 60s, he worked with federal officials to establish a national center committed to poverty research and research on the nature, causes, consequences, and policies and programs to ameliorate poverty and social inequality. And in 1966, IRP became the first center, first national poverty center. So if you can do the math, we're celebrating our 50th anniversary this year. So there have been lots of progress, both in research and in policy. Obviously, we haven't put ourselves out of business, so there is still a lot more to do. But we are continuing in Bob's vision and to do the work that he started. So Bob died in 1997, and the Lampman family and their friends worked with IRP and the economics department to establish this series. And we bring in eminent poverty scholars from around the country. That focus on the topics to which Bob devoted his career. So today's speaker, Janet Currie, is among the very top scholars in the world focusing on issues of poverty and inequality. She particularly focuses on social and economic factors, social policies and programs, and health and well-being. I'm guessing that most, if not all of you, are pretty familiar with her work. But just to give you a little more of her background, so she's the Henry Putnam Professor of Economics and Public Affairs at Princeton, where she's also the chair of the Economics Department and the director of the Center for Health and Well-Being. She's a member of the Institute for Medicine, a fellow of the American Academy of Arts and Sciences, the American Academy of Political and Social Sciences, and the Econometric Society. She's past vice president of the American Economic Association, past president of the Society for Labor Economics. She's on the board of reviewing editors of Science Magazine and the editorial board of Quarterly Journal of Economics. So we are incredibly thrilled that she could fit us into her busy schedule. So Janet's a meticulous and prolific researcher, so her publications span pretty much every topic connected at all to child health, development, and well-being, including early intervention programs, expansions of public health insurance programs, public housing, and food and nutrition programs. She's particularly focused on socioeconomic differences in child health, environmental threats to child health, and the long-term effects of poor health in early childhood. She's won numerous awards, and really notably not just for her research, but also for her advising and mentorship, both at the university she's been in and nationally. So I'm thrilled that Janet can join us today to talk about her work on the long-term consequences of children's health and circumstances. And it's a great pleasure to introduce her. So please join me in welcoming Janet.
So thank you all very much for coming, and all the excitement with the technical things notwithstanding. I'm really pleased to be here. So as Lenny said, I'm going to talk about the long-term consequences of child health and circumstances, which is something that I've been working on now for quite a long time. So I guess a starting point for this lecture is the idea that pregnancy and early childhood are really critical periods for child development. So I guess the idea of looking at nature versus nurture is one that has a long history here in Wisconsin. But nowadays people think that both nature and nurture, and especially their interaction, are very important. One way that this happens is through gene expression, and the idea is that environment affects gene expression. So the environment may then serve either to reinforce or to mitigate initial differences. There are many studies now that are linking health at birth to future outcomes. And a lot of this research, and a lot of the research that I'm going to talk about today, focuses on birth weight as one indicator of health at birth. The main reason for looking at birth weight is that it's well measured over a long period of time and in many different populations. I wouldn't suggest that birth weight is the only thing that's important, but it is something that we can observe. And interestingly enough, you can show that there's a relationship between birth weight and future outcomes, even basically in the raw data. So one example is from the National Longitudinal Survey of Youth, which is a nationally representative survey that started with people between the ages of 14 and 21 in 1978. Those people have been followed up, and also the children of the mothers who were in the initial survey have been followed up over time. So those children now, or at least at the time that they were measured in the survey, are 24 to 27 years old. And if I just plot their birth weight against their earnings at 24 to 27, you see a relatively linear relationship. So the point here is just to show something which I thought initially was quite surprising, is just that there's this relationship between birth weight and future outcomes. Now, people have explored this relationship in much more rigorous ways, including looking at comparisons between children at different birth weights. So the idea here is that siblings are a natural control group for the index child because they share a lot of the same background. In the case of twins, the family background is even more similar, although I don't want to sort of overstate the case for comparing siblings. Of course, different children, even in the same family, can be treated differently. But using this kind of design, people have shown that birth weight is related to education. And the research in this area includes large-scale studies from Scandinavian countries, but also Chile, US, Britain, and Canada. A relationship has also been shown between birth weight and earnings. These studies are mostly in Scandinavia because it's harder to get earnings data. And studies have shown the relationship between birth weight and health. And again, these studies, a lot of them are done in Scandinavia, but some have been done in the US and Canada. So one of the first and really most impressive studies of this type was done by Sandra Black, Paul Devereaux, and Charles Savanas. This was one of the first studies to use these sibling and twin comparisons to look at the longer-term effects of birth weight. It focused on all Norwegian births between 1967 and 1997. Okay, so they focused on twins, and they're able to match the birth records to the administrative records for earnings, for IQ, for all kinds of things. For men, the IQ scores come from military records because all of the boys of a certain age were tested. And when you look at this, you see a clear relationship. Now, there's a lot of noise here. This is showing birth weight on the x-axis and probability of graduating high school on the y-axis.
The reason why there's a lot of noise at both ends is because there's not very many kids who were either very low birth weight, below 1,500 grams, or very high birth weight, above, say, 3,800 grams, who survived. So if you focus on the sort of middle part of the distribution there, it's upward sloping. There's 3 different lines, which are showing 3 different subsamples. So the white dots are for kids who weren't twins. The other 2 lines are for kids who were twins, and one of those other 2 lines is for sibling comparisons, and the other one is showing ordinary least squares estimates. So you can see it doesn't really make very much difference for the twin sample whether you use twin fixed effects or not. You still see this upward sloping relationship. In terms of magnitudes, what it's showing is if you compared twins, a twin who was 3,500 grams, or about 7.5 pounds, would be 10% more likely to finish high school than a twin who was about 4 pounds. Okay, so that's quite a large effect associated with birth weight. Looking at other outcomes, you can also look at IQ, as I mentioned, earnings, or even height. And here, the pale blue bar is for ordinary least squares estimates, and the dark blue is for the twin fixed effect. You can see there's some small differences, but the overall trend is the same, whether you use one type of estimation strategy or the other. And so here you're showing similar size effects on IQ and earnings, slightly smaller effects of height. But these are, again, long-lasting effects of birth weight. In work with Enrico Moretti, we showed similar long-term effects using data from the US. In the US, we don't have sort of administrative registries where you can just go find data about everybody. So what we did was to use birth records for California and to link together 3 generations of records. The way that we did that was by starting with mothers who had just given birth. On the birth record, you have the name of the mother's mother, so then we could go back and find the grandmothers. So you can think about grandmothers, mothers, and babies. Then we could compare mothers who were sisters and say, if one of the mothers was low birth weight and the other one wasn't, what was the average difference in the health of the, or outcomes of the cousins? So the interesting finding here is that the sister who was low birth weight had less education and was more likely to live in a high poverty zip code at the time that she gave birth to her own child. But not only that, the effect varied with whether the sister was herself born in a high poverty zip code. So just to give some idea of the magnitudes, what this figure is trying to show is that the effect of maternal low birth weight on the mother's outcomes is, first of all, you're less likely to be in a high income place and have less education, which is what you see on the far left side. But then the next 2 sets of bars are separated into whether the mother was born in a low-income zip code or whether the mother was born in a high-income zip code. So you can see that almost all of the negative effect of the mother's low birth weight is concentrated among mothers who are also born in a poor place. Okay, so what I think this shows is that there's a strong role of the environment, so that even though 2 different people may both be born low birth weight, whether that's going to go on to have a negative effect on them or not is going to depend on the richness of their environment and whether the effect can be remediated. Another important aspect of health at birth is that it seems that it can be induced from one generation to another. So going back to the nature versus nurture idea, we have a tendency to think that something that we observe at birth that's transmitted from one generation to the other must be genetic. But in experiments with animals, such as rats, you can show that if you take the mother rats, starve them while they're pregnant, then the baby rats will be born small. That's not very surprising. But what's more surprising is that if you take those baby rats, rear them under optimal conditions, and then they go on and have more babies, the grand rats, if you like, will also be small. So if the mother was of low birth weight, even if she was reared under optimal conditions. Okay, so something that looks like an inherited effect can actually be induced by the environment and can persist across at least 2 generations. Now, of course, for humans, we don't do that. We don't starve people when they're pregnant and then see what happens, at least not intentionally. But you can sort of approximate this idea in the California data, looking at mothers who are sisters and looking at the effect of the mother's low birth weight on the infant's probability of being low birth weight. Okay, so when you do that, what you see, again, on the far left is the overall effect. So if the mother was low birth weight, the child is more likely to be low birth weight. But this effect is bigger if the mother is living at the time of the child's birth in a high poverty zip code than if she's living in a low poverty zip code. So again, there seems to be a mitigating effect of the environment on this transmission of low birth weight from one generation to the other. So just to sort of summarize what I'm getting at so far, I'm trying to argue that health at birth is an important aspect of child development, which has been linked to future outcomes, including earnings, employment, education, and even the health of the next generation. So that given this evidence, large inequalities at health at birth ought to be very disturbing. And unfortunately, if you look at the US data, that's exactly what you see. It's really large inequalities in health at birth. So what this figure is showing is it's based on the US vital statistics natality data, that is the birth certificates, which are collected for everybody. It includes 36 states, so 14 states that are missing one or another piece of information are excluded. It's for people 19 to 39, so I'm not worrying here about teen moms or really older moms. And I'm looking only at single births because we know that twins are more likely to be low birth weight, so it's a relatively uniform group. And we can just do contrasts. So if we compare African Americans to non-African Americans, or if we compare among the non-African Americans people with less than high school to people with college, or mothers who are single at the time of the birth compared to mothers who are married, or in the far right, I'm trying to look at sort of cumulative disadvantage, African American mothers with less than high school education compared to white college educated mothers. You see these very large differences in the probability that the baby is born low birth weight. Okay, so we're seeing huge inequalities in health at birth. So that's kind of the bad news. The good news is that these disadvantages seem to be diminishing over time. So here the disadvantaged group is African American mothers with less than high school education. The more advantaged group is white mothers with college education. You can see there's still a huge disparity in the probability of low birth weight, but that it's changed quite a bit from 1989 to 2011. Now, if you look at babies after they're born, up to about age 4, you see similar declines in mortality. Okay, so this figure is a little bit complicated. I'm going to try and explain exactly what it is. This is based on death rates for groups of counties, where counties have been split into 20 groups so that each one accounts for about 5% of the US population. And then the county groups are just ranked from the poorest on the left-hand side to, the reverse. They're ranked by the poverty percentile. So on the left-hand side, you have the richest, and on the right-hand side, you have the poorest. Okay, so all the lines slope up, which is showing that mortality rates are higher in the poor counties than in the rich counties. Okay. Now the blue dots are the numbers for 1990, and the green dots are the numbers for 2010. Okay. There's two different sets of numbers for 2010 because in the census now we allow people to choose more than one race, and many more people now choose more than one race. So the green dots here are people who said they were black but no other race, and the red dots are people who said they were black plus some other race, potentially. Okay, so you can see that makes a slight difference. But overall, the story is that you have a big decline in mortality, and the mortality decline is bigger on the right-hand side of the graph than on the left-hand side of the graph, indicating that the inequality in mortality has decreased over the past 20 years. Okay, so I know everybody has been reading in the paper almost every day that mortality inequality is increasing. That's because all those other studies are looking at people 45 and older, and mortality inequality has increased for people 45 and older. That may be for all kinds of reasons, like trends in smoking behavior. But if you look at infants, children, and even young adults, what you see is big declines in mortality inequality. Okay. Also, here I'm splitting into white and black people. And what you can see is that for blacks, there have been huge declines in mortality, pretty much across the board. Okay, so this is, I think, a good news story that's not being told, that inequality in mortality is really increasing for children. I think this augurs well for the health of these children as they get older, and that more people should know about this because this is a big public health success story. So I'm going to talk for most of the remaining part of this lecture about why I think this has happened. What are the things that are driving this big decline in mortality and mortality inequality among young people? Okay, so that's just summarizing what I just said. Okay, so I think these time trends pose a little bit of a puzzle because we know that child health is strongly linked to socioeconomic status. I showed you that at the beginning. We also know that inequalities in socioeconomic status have been growing over time. We've heard a tremendous amount about increases in inequality. Yet these inequalities in child health are rapidly reducing. Okay, so something is kind of swimming against the tide. So what types of factors might account for this reduction in inequality among infants and children? Some possible factors might be changes in fertility. So for example, if different people are having children, then you might get different kinds of child health outcomes. A second thing, which I think is really important, is improvements in medical care and also improvements in access to medical care. People sometimes forget that in the late 80s and 90s, we expanded health insurance for poor pregnant women and children, so that now all poor children under age 18 are covered by public health insurance, and in many states, kids are covered up to 300% of the poverty line. So that's a real accomplishment. There are also long-term improvements in maternal health, which given the evidence about intergenerational transmission of health might be expected to improve child health. There have been changes in maternal health behaviors, and there are also large reductions in pollution over the past 20 years. So thinking about these different possibilities in order, could this trend be due to changes in fertility? I guess the short answer to that question is I don't think so. The share of births in the most disadvantaged groups is fairly constant over time, and actually partly because more women are getting more education, the share of births to more educated women is increasing over time. Okay, so I don't think these trends can explain what's going on. What about improvements in medical care for pregnant women and children? As I mentioned, the US greatly expanded public health insurance for pregnant women and young children beginning in the 1980s. In some earlier work, I showed that this had an effect on infant mortality. More recently, there have been several studies looking at the long-term effects on kids who received health insurance as a result of these public health insurance expansions. So the Weary et al. Study looks at effects on hospitalizations. The Weary and Meyer paper looks at effects on mortality. And the Kowalski study looks at the tax records and looks at effects on people's earnings. And all of these studies actually independently argue that the kids who were covered since birth as a result of the expansions are doing better in all of these dimensions. So how did these changes in health insurance work? This figure is showing for Texas how the expansions were phased in for different groups. So you can see here the bottom line is people aged 13 to 17, that's the yellow one. Then there's people 9 to 12, 4 to 8, and the top line is 0 to 3. So you can see, for example, that in Texas, they started covering kids 0 to 3 first, and then eventually they also covered the 13 to 17-year-olds. So this process was going on at different rates in different states, and overall, you get a picture that looks something like this in terms of the fraction of children of different ages covered. So just to take an example from one of the studies that I mentioned, looking at hospitalizations, this figure used a regression discontinuity design. So here, that vertical line at 0 represents September 1, 1983. So the dots on the left-hand side are cohorts who were born before September 1, 1983, and they didn't get the expanded health insurance. And then the cohorts on the right are all the people who did get expanded health insurance coverage as a result of the expansions. And what the figure is showing is that drop in hospitalizations among black children. Black children were the most likely to get health insurance as a result of the expansions because black children have much higher poverty rates. Okay. Interestingly enough, if you start looking at causes, a lot of these hospitalizations are mental health hospitalizations. So what the paper is suggesting is that giving kids health insurance from birth or before birth over time seems to reduce hospitalizations, especially for mental health problems. This is a direction, even though we've come a long way, we could go further. There are other improvements in healthcare that might also improve outcomes, including really simple things like vaccination for influenza. Vaccination rates for pregnant women are pretty low. Nobody likes to vaccinate pregnant women, even though the CDC has been telling doctors to do this for a long time. Most doctors still don't do it. The vaccination rate did go up after 2009, but it's still sort of hovering around 50%, leaving a lot of room for improvement. By increasing inflammation, influenza is taught to trigger preterm labor, which is one of the main causes of low birth weight. And it may have also more subtle effects on the developing fetus. In a paper with Hannah Schwandt in 2013, we looked at the effect of influenza on pregnancy outcomes using birth data for Pennsylvania, New Jersey, and New York City, which allowed us to link births to the same mother. So we could compare siblings where one sibling was born at a time of high flu prevalence and the other one wasn't. A nice thing about flu from the point of view of trying to identify effects is that it's so seasonal, and also the seasons move around slightly. So what you see, if you look at gestation length and sort of line it up, is that babies who were conceived in May tend to have the shortest gestation length, and that may be because they tend to be born in high flu season. So if you're conceived in May, you're born in January or February, which is when you have the most flu. Okay? So these two figures kind of line up that dip in gestation length with the spike in influenza in influenza patients. The different colored lines here are showing different ways of controlling for other factors. So the blue line is showing ordinary least squares. The red line is ordinary least squares plus some more controls. And then the green line is comparing siblings who happen to be born at different times. Okay, so this is a really strong relationship. And as I mentioned, flu kind of moves around. And in particularly, the H1N1 epidemic had a really different pattern than other years in that it peaked much earlier. So if you remember, people were lining up trying to get vaccinated in October instead of in January or February. So what you can see here in the red line is the data for 2009, the H1N1 year, and you can see that the dip in gestation occurs earlier, and also the spike in flu rates appeared earlier. Another thing that could be going on is improvements in the mother's own health. So healthier mothers should have healthier children. And there are some very large effects on maternal health, partly due to the Civil Rights Act. So we were talking actually at lunch about a paper that Ken Shea did showing that the Civil Rights Act resulted in many more babies being born in hospitals because hospitals were not allowed to be segregated and refused to serve people. And if you look at the data on neonatal mortality rates in the South, you see really dramatic effects. So this figure, which is for Georgia, shows the neonatal mortality rate. So this is rates after the first month of life, which mostly are due to infectious diseases at this time period. The green line at the top is the rate for blacks. The red line is the rate for whites, and then the blue is the average. So you can see the huge difference in mortality rates for black and white babies in the 60s. You can also see how rapidly they converge. So they remain, too far apart, but it's a really big improvement from the situation in the 60s. So the question is, if you took these mothers who benefited from civil rights and had lower mortality rates, and then you follow them up and say, what happened to their children? Do you see any effect of this big improvement in maternal health? In a study that I did with Doug Almond and Marisa Hermann, we looked at this question using state year level data. We aggregated into cells by the year of birth, age, race, child's state, and year of birth. And what we show is that an additional post-neonatal death per 1,000 in the year after the mother's birth, which is kind of an indicator of the infectious disease environment, is associated with a 1.8% higher probability of the mother having diabetes at the time that she gives birth. This rate is 3.5% higher for black mothers and 1.4% higher for white mothers. So this suggests that conditions early in the mother's childhood contribute to her health many years later at the time that she gives birth to her own child. So that improvements in maternal health probably have had an impact on improvements in child health. Another factor that I mentioned was reductions in pollution. This picture is actually from the EPA website, and is a stock photo showing something about their toxic release inventory. So the toxic release inventory is a program that was started after the Bhopal disaster, and it's also known as the Community Right to Know Act. It's a very interesting law because it doesn't actually say that people can't pollute or impose penalties for polluting. What it does is it says that if a factory is using any one of a number of listed chemicals, they have to report to the EPA what their emissions are. So it's actually a real economist type of law in that it's saying, well, the problem here is that people don't know, and so what we'll do is we'll make sure that they do know, and then we'll just let the market or the court system or whatever take care of it. Okay. So I'll talk some more about the toxic release inventory in a minute, but right now what I want to point out is that criteria air pollutants have fallen. We tend to think about the Clean Air Act in the 1970s as being a watershed moment, and after that, the pollution fell a lot. But what people might not know is that even if you look from 1990 to now, pollution has continued to fall. So these are the so-called Criterion Air Pollutants, which are the ones that are required to be monitored by the EPA. And so you can see lead in the air has declined a good deal. Ozone is fairly flat, but is declining a little bit. Carbon monoxide, which mainly comes from cars in urban areas, is declining fairly steeply. Also particulates, nitrous oxides, sulfur dioxide, those are all declining over time. Okay. These pollutants have been linked to infant health. So one study that I did looked at all the New Jersey births between 1989 and 2003. Again, we were able to use a confidential version of the data that allowed us to link births to the same mother. We used only mothers who lived within 10 kilometers of an air quality monitor in an effort to try and get reasonably accurate measures of the air pollution levels, and then compared the health of siblings who were exposed to different amounts of pollution. This figure summarizes the results. So again, on the left, you see the overall estimate, which is slightly less than 0.01. That translates into about a 10% increase in the probability of low birth weight for a 1 unit change in carbon monoxide, which is what this figure is about. But more interesting, I think, is that if you look at the other bars, what they're showing is that the effects are a lot larger if the mother had other risk factors for the pregnancy already. So there's kind of a cumulative disadvantage here. If the mother was a smoker, you get a much larger effect. If the mother was over 35, if the mother had other risk factors like diabetes or hypertension, you also get a larger effect. So what this is saying is that the same negative shock may have a lot bigger effect on some people than on others. Also, disadvantaged mothers are more likely to be exposed to pollution. So they're more likely to live near busy roads, more likely to live near Superfund hazardous waste sites, more likely to live near factories that emit toxic releases. So this figure is just showing for 5 large states what is the probability of living within 1.24 miles of a toxic release inventory site. Somewhat shockingly, for all the white women, the probability is 40%. For black women, it's 60%. So many people are being exposed to these kinds of pollutants. We don't know very much, though, about whether any of these pollutants are actually harmful. The EPA only began monitoring the non-criterion hazardous air pollutants, or HAPs, in 1998. And in 1998, they had very few monitors. By 2003, they keep adding monitors, and so there were 84 different HAPs being monitored. I think one of the difficulties in studying this is that we really don't have any idea like how close you have to be to one of these factories to have any negative health effect. I thought this was something that the engineering literature would be able to tell me, but it didn't. So the first problem was just to answer that question, how far do you have to be away from one of these factories for it not to be affecting you anymore? And in order to answer that question, we matched the monitoring stations with the factories. So these graphs are just showing for specific chemicals what we found. On the top, there's a line that shows whether we could detect it by how far away you were from the plant. And so you can see for benzene, it kind of fades out about 1 mile. On the bottom is a graph showing how many monitors we had at different distances, so you can get some idea about what the support is. Okay, so we can look at different pollutants, and we thought that, okay, when you're about 1 mile away, it seems like for a lot of these pollutants, you're not detecting it anymore. So using that idea, we compared infants who lived within 1 mile of an operating toxic release inventory plant to infants who lived 1 to 2 miles from the plant. The reason for picking those two groups was we were trying to pick groups who would be similarly affected by the economic impact of a plant opening or closing, right? Because people like plants because they create jobs. So we thought there wasn't too much difference in terms of whether you would get a job at the plant or benefit from it that way at 1 mile or 1 to 2 miles. And so this graph summarizes the result. What you see is that there's a significantly higher probability of having birth weight between 1,500 and 2,000 grams if people were less than 1 mile from a plant. And then it fades out. So the implication here, you can do a back-of-the-envelope calculation saying, okay, well, we know what the distribution of distances from plants are. We know that, as I showed you, that black women are more likely to live close to a plant than white women. So how much of the gap could we explain using these differences in exposure to toxic releases? And we estimate that about 6% of the gap might be due to differential exposure. I guess the last sort of topic that I want to cover is talking about unhealthy behaviors. Some of the behaviors that can be examined on the birth certificate include the use of prenatal care, weight gain during pregnancy, and smoking. And we can also observe whether people have obesity, hypertension, or diabetes. There are big gaps in unhealthy behaviors by group. So if we compare the most advantaged mothers and the most disadvantaged mothers, the most disadvantaged mothers are more likely to have diabetes, more likely to have hypertension, much more likely to smoke during pregnancy, and more likely to be obese. But again, those gaps have been changing over time. So I was actually quite surprised when I looked into this, because we know that blacks are less likely to smoke than whites on average. But if we look at pregnant women and disadvantaged black mothers, they're actually more likely to smoke than white mothers. But that gap has been changing over time. And if we kind of overlay the smoking gap on the low birth weight gap, the two things track each other very well. Okay, so the reduction in smoking that we've seen, which is due to aggressive anti-smoking policy, at least in part, like cigarette taxes and bans on smoking in the workplace, seems to have had an effect on smoking behavior, which has had a positive effect on health. Other trends are not so positive. One is weight gain during pregnancy. So this figure here is just a non-parametric figure of probability of low birth weight with weight gain during pregnancy, based on several years of vital statistics natality data. And so you can see it has a very pronounced U shape. So if the optimum birth amount of weight gain during pregnancy is something like 30 to 40 pounds. If you're less than that, you have a lot higher probability of low birth weight. If you're more than that, you have a lot higher probability of low birth weight. So if we look at what's going on with those two tails, either weight gain less than 15 pounds or weight gain more than 60 pounds, that's going up for all education groups. Okay? So that's one trend that's going in the wrong direction. So just to summarize, what factors can account for the reductions in inequality at birth in the face of increasing economic inequality? Of the factors that I listed, I think all of them except changes in fertility are probably important. In terms of other things, which I don't have time to talk about today, there is work showing that feeding programs, such as a supplemental nutrition program for women, infants, and children, has had a positive effect. Income transfers, like the increase in the EITC, have had positive effects on infant health. And also, child care programs can have positive effects on preschool children. So just to conclude, health at birth is very strongly linked to socioeconomic status, but inequalities in economic status have increased over the last 25 years, while inequalities in the health of young children have decreased. I think this suggests that we don't have to be resigned to health inequalities, but that public policy can really work with the family to improve outcomes for disadvantaged women and their children, even if family incomes are deteriorating. So the policies, again, that are most responsible, in my opinion, are improvements in access to medical care, reductions in pollution, reductions in smoking. And that's it. Thank you.
So can you talk a little bit about the different options or sort of, clearly you would say the substitutes, but sort of where you see the most progress being made with more access to healthcare, more health improvements, boosting the medical system, and sort of where you would start, where you would put money?
So, yeah, it's kind of hard to say all of the above. So I think I would start in a pragmatic way with trying to keep programs that we know are successful. So something, S-CHIP will be up for reauthorization. It's not totally clear what the fate of S-CHIP is going to be in the new health insurance landscape. So I think it's very important to make sure that, we don't lose ground on those kind of important programs. The same thing is true for anti-smoking efforts. So a lot of states made a big effort with the tobacco settlement. They got money, they put it into anti-smoking initiatives. Those were relatively successful. And there's a lot of backsliding. And you do see increases in smoking rates among pregnant women in some states that have been diverting tobacco money to other, to fill budget holes.
We've been hearing a lot about lead lately, and I've often wondered if there's been efforts to link differential outcomes from the lead phase down in gasoline during the 70s and 80s, and if so, if those have been large effects and what they might tell us about sort of the more recent worries about lead in drinking water and the like.
Yeah, there's actually quite a history of literature looking at the effect of lead on children, using the phase out of lead from gasoline especially. And that literature does suggest large effects. I guess there's some quibbles about exactly how large the effects are, but I think everybody thinks that lead is very bad. What's going on recently, I think it's important to kind of keep it in perspective in the sense that
the races inside of the decreases.
There's a huge difference.
There's a huge difference by race. The data on lead exposure is not actually very good. So what they use to predict lead exposure is they say, let's look at areas where there's lots of poor kids living in old housing. And we say those kids are at risk for lead. Most states don't do comprehensive lead testing. And so when you go online and look at CDC figures for the fraction of kids with lead poisoning, what it'll say is the fraction of kids who were tested and tested above some level is whatever it is. But what they don't say is that not very many kids were actually even tested. Okay, but what we do know is of the kids who come in and get tested and end up having very high lead levels, most of those kids are poor black kids in older urban areas.
Thanks, Janet. That's very interesting. Dave Figlio had an article in the AER in December 2014 where he showed every birth in Florida. He followed every kid in Florida for 11 years. And what he showed was that low birth weight had a negative coefficient, all else equal on everything. But the kids in high SES with low birth weight born in the high SES environments could recover. So it's not, just like it's not all over before you start preschool or before you start, you can compensate in some ways. And I think that's why the income and the feeding and the other things, which probably have effects beyond birth themselves, as well as continued health care, can make a difference. Do you agree?
Yeah, I totally agree. I guess I was trying to show some of those types of interactions earlier. You know, the effect of low birth weight is different if the mother was born in a high-income place, if she was living in a high-income place. Those are sort of proxies for other types of advantages that help you to ameliorate the effects. So definitely, I don't want anybody to go away thinking that, you know, there's nothing you can do, because clearly there's a lot that can be done.
That's what I wanted.
Hello. How does the mother's health literacy, as reflected by her knowledge of food and eating, home cooking, daily physical activity, factor in?
Okay, so we do know a little bit about maternal education and child outcomes, which isn't exactly what you're asking. I think we don't know that much for large samples of women about exactly what their health literacy is. There's some discrepancy. So I have a paper with Enrico Moretti showing that mothers who got college education because a college opened near them had children who were healthier. And when we look at behaviors, the main reason why they were healthier is because they're way less likely to smoke. So it seems like there's perhaps a causal effect of college education on smoking. On the other hand, several people have done a similar sort of thing looking at high school education, saying, you know, if you increase the age at which you can leave school, then some mothers are forced to get an additional year of high school education. Does that have any effect on their child's health? Nobody sees any effect of that, right? So an additional year of high school education doesn't affect people's smoking behavior, doesn't affect their health.
Hi, very interesting talk. The kinds of later life indicators that you show us, graduation rates from high school, and of course in other work, employment-related indicators, tend to tell us about mean effects. I think we live in times of increased economic volatility, and I wonder whether the literature is starting to emerge with any information on vulnerability to shocks graded across these same kinds of birth indicators.
Yeah, actually, that's something that you could look at using the kinds of administrative data sets that people are looking at, especially something like unemployment insurance records or tax records tell you whether people are employed or not. So you can look not just at whether somebody's employed at a point in time, but you could look, say, over a 10-year period, what fraction of the time were they employed, what fraction of the time were they on unemployment insurance or something like that. So that hasn't been done very much, but it certainly could be done.
Comparisons internationally, is it too difficult to compare, for example, a system that has a more universal healthcare system or different educational systems in terms of the actual improvement or incomes of the children over time?
Yeah, so I'm actually doing, I think that's a great question. I'm actually doing a study trying to look at Canada versus the US and see whether these, my prior is that because they have public health insurance in Canada, that you would see less of a decline in inequality looking at Canadian children than looking at American children, but I don't know whether that's true or not yet.
Very nice talk. You use low birth weight, and I have no problem with you using that, but I wonder if you could say a little about the use of alternative measures like small for gestational age or pregnancy loss, and whether the evidence looks like it's all going in that same direction, or whether instead you see some kind of substitute poor outcomes amongst the more disadvantaged.
Yeah, so I know a lot of doctors think that you should use small for gestational age. The main reason why I don't use it is because the gestation data is awful, which you can see very easily. Because if you just plot it out, you get this huge spike at like exactly 39 weeks. And we know that data doesn't look like that in the real world. So whereas if you look at birth weight, you have like a nice distribution. Right? So birth weight is measured by a professional at the time of the birth. And arguably, I guess gestation is also imputed by professionals, but they don't do a very good job of it. Or they don't do a very good job of it. So that's why I don't use that. I think it would be great to have another measure that was more predictive, but I haven't seen very much progress on that over the last several years.
Did you see any kind of substitution, any indicators that maybe there's more pregnancy loss among the disadvantaged? Because that would be consistent with what you're finding.
Well, pregnancy loss, the data is also awful. So a lot of states you're not required to report pregnancy losses before 6 months. And we know that most pregnancy losses are much earlier in the pregnancy. So the bulk of the pregnancy losses are not recorded in any data. And in fact, women themselves might not even know that they had a pregnancy loss for some of them. So yeah, so I think that's a really interesting idea to think about. And there's the whole, sex ratios thing, that boys are more fragile than girls, and so you might see changes in sex ratios and so on. But the fetal losses is very difficult to think about how we're ever going to get data to look at that.
Thank you very much.
Thank you.